side, so you guys can always message him, Chris Barnes. I think I put it in the calendar invite to the committee at least, but.
No, it's on my end. I have this like external Logitech camera, and it always, anytime I do a Skype or a Zoom, I think it's just too much bandwidth and it always just kicks me off. So I won't have video, but I can see your presentation.
Okay.
All right, Jason, let me just introduce your committee. And first of all, so I'm Ann Thackeray, for those of you who don't know me, and I've worked closely with Jason throughout this process. And it's been a great experience for me as well. But this is kind of exciting to have all this done, all this work culminate in a virtual experience. Unfortunately for Jason, we're not here in person to celebrate with him, but he has really worked hard in these past few months, making sense of all the data that he has been filtering through and collected. So we have a combination of retrospective data as well as original data, and we'll see these multiple methods presented here today. So thank you all for joining us and giving him that support. I just want to introduce the other members of his committee. So we have Dr. Julie Fritz from the College of Health, Dr. Brooke Martin, who's the Department of Orthopedics, Dr. Megan Vanneman from Population Health Sciences, and Jake Magel, Dr. Jake Magel from the College of Health as well. And this committee has really been active in discussing discussing the data and giving Jason feedback. And I thank the committee as well for their support over these last several years. So right now, this is how we'll run it, is we're going to give the time to Jason. He'll present uninterrupted, and then we'll open it for some questions at the end to the whole group, after which we'll ask everyone except the committee to leave and may have a few additional questions for Jason, and we'll go from that point on. But for now, it's time for Jason.
Yeah, thank you, Ann. So I want to thank everyone for taking the time out of their day, especially during the crisis and pandemic that we have going on, and also being flexible and allowing me to present my dissertation in this virtual format. I do want to apologize if there's any issues, technical or otherwise. We'll try to work through them. There shouldn't be any, but once again, thank you to everyone for coming. And what I'm going to talk about is the work that I've done with Ann and the other committee members over the past 4 years to look at patients and their choices that they make within the healthcare system, particularly towards physical therapy for patients suffering from musculoskeletal conditions with multiple methods. I know Ann introduced it's not progressing. Sorry, little issue progressing. It's not progressing for some reason. Oh, there we go. I want to, I have acknowledgements at the end, but I also want to thank everyone on the committee. I did ask a lot of the committee and everyone was super helpful. And acting as chair, she was very helpful with the qualitative component, which is one of my studies. It takes 2 people to do the coding, so I needed some help there. And that's a lot to ask, especially from a main mentor. Julie and Jake provided much needed research, experience and mentorship and a physical therapy perspective. Brooke and Megan brought a non-physical therapy perspective, created an interdisciplinary committee. Also kind of kept my feet on the ground as a physical therapist, because PTs tend to, really think with a PT mind, and I really had to learn how not to do that so much within this project. Brooke helped especially with the statistical analyses in aim 1 and aim 3. Megan was super helpful with the qualitative aims. All right, so what I'm going to do is I'm going to go through a very short background of why I did the study that I did, the studies that I did. With each study, I'm going to go through why I did it, the purpose, introduce it a little bit more, talk about how I did it with the methods, the results, what we found, and then a little bit of discussion. And then at the end, I'm going to conclude with where I think these studies can be applied maybe in the future within health systems and by other researchers, and how it's also going to move research forward and other steps that I could see. Okay, I'm going to start with the background and why I ended up doing these studies. All of this started because I am a physical therapist and I'm musculoskeletal focused. I did all my training as a musculoskeletal physical therapist within outpatient orthopedic clinics. And I saw a variety of patients, and we saw a lot of patients, particularly from a variety of different backgrounds, and they tended to have a lot of trouble accessing physical therapy. So it created a lot of questions as a clinician, leading me to end up doing a PhD. So there's several different reasons why musculoskeletal care is important. And what I'm going to do is I'm going to start here, I'm going to go down, across, and then back up. So why is musculoskeletal care and musculoskeletal problems studied? Number one, because it's expensive. So in a 2020 study, and I'm going to apologize if I butcher any authors' names, and sometimes I just won't even say them so I don't butcher them, but they found that in 2016 in the US, musculoskeletal care cost the most out of any condition that they had studied. It was up to $381 billion in 2016. Globally, anywhere from a fifth to a third of people live with a painful musculoskeletal condition. So musculoskeletal care and conditions cause a significant burden to the healthcare system. So that has pushed research to look at, what types of treatments are cost effective. There's been ample evidence supporting physical therapy, particularly in back and neck pain, but also in several other conditions, shoulders, hips, knees. So in at least 7 different conditions, there's either evidence, research evidence, or treatment-based guidelines supporting physical therapy. What I couldn't, out of the musculoskeletal conditions, I couldn't find a ton of evidence for thoracic pain, wrist and hand, particularly for non-operative physical therapy. But I'm not saying it's not out there, it's just not super prevalent. So, like I said, out of these 7 conditions, primarily in back and neck pain, there has been a lot of research looking at the effectiveness of physical therapy, but also looking at, if we know physical therapy is effective, how many people are actually getting referred to physical therapy? And it's also pushed research towards how many people are actually using physical therapy. And these studies are often done differently. What I mean by differently is separately. So you either look at referral rates or use rates to try to see how often physical therapy is being used. So anywhere from 10 to 55% of people, primarily in back and neck pain, these research studies have been done, are referred to physical therapy. What's been happening recently, and probably recently in the research, is that referral rates seem to be increasing based on those past treatment guidelines and research. But when you look at the use rates, which are separate studies, use rates of physical therapy recently don't seem to be increasing. So anywhere from 16 to 33% of people end up using physical therapy during their episodic care. There have been 2 studies recently done, one by Ann and one by Aguirre in 2019. So Ann's study was done with colleagues looking at patients with lower back pain with Medicaid, using Medicaid, and looked at how many people were referred and how many people ended up using, kind of bridging this gap between use and referral. And then in pelvic floor pain is the 2019 study. They did the same thing, looking at barriers towards patients being able to access physical therapy. So what's happening is there's a problem because the referral rates seem to be increasing. There's evidence supporting physical therapy, but use rates aren't increasing. I think this comes mostly from the idea that we kind of put patients in a passive role within the healthcare system, and it's assumed that the providers are the ones that drive care. So in the healthcare system, most of the research is focused either on the physician or the physical therapist. So the use rate research focuses on the physical therapist, who largely get patients through referrals. And then the referral rate focuses on the physicians who then refer patients. So it is assumed that when a patient comes into a physician or another healthcare provider, that when the healthcare provider sees that that patient has musculoskeletal pain and refers them to physical therapy, that they end up going. And the clinical practice guidelines and research has really pushed this and has been effective, it looks like, at increasing referral rates. But I think what has what has been missed is that we're missing the big part of the healthcare system, which is the patient in the middle. So after that referral from the physician or healthcare provider, we assume that the patient just takes that and uses it and goes to the physical therapist. But the past research seems to indicate that maybe something else is going on. The patient is essentially, after referral, left to navigate the system independent. So there is several evidence gaps within the current research, which I think has led to what seems to be reduced use or low uses of physical therapy, but we really can't tell whether the uses are low right now, even though referral rates are going up and use rates are stagnant. So first, we don't know which patients end up using physical therapy after referral for musculoskeletal conditions and how often that happens. So like I said, in Ann's article in the 2009 and the 2019 pelvic floor article, they've bridged that gap. But outside of those diagnoses and those specific groups, we don't know in a general musculoskeletal population, if a patient gets a referral, how often they're going to use that and which types of patients end up using that referral. Second, once a patient gets a referral or in the health system, we don't know how patients choose physical therapy and what factors really influence that choice. Third, if a patient ends up going to physical therapy, or if a patient gets a referral and doesn't end up going to physical therapy, we don't know if there's a difference there in their outcomes, including patient-reported outcomes, which measure function, and then also costs and medical utilization. So I focus more on medical utilization just based on where the evidence is, but we still don't know if a patient ends up going to physical therapy, are they more or less likely to have a better outcome? All three of these are barriers to increasing access to physical therapy appropriately for the right patient at the right time that we currently cannot answer. So my dissertation tried to answer these questions. So what we did is we examined patient choice and use of physical therapy for a wide variety of musculoskeletal conditions using multiple methods. What I mean by multiple methods is we used both data from the healthcare system and ran statistics on it. And we also did interview studies to see how patients end up making choices within the healthcare system. All right, with each project, I have 3 different ones. I'm gonna go through the purpose, the methods, the results. I don't have the p-values on everything because I only included results that I'm presenting today that had a p-value less than 0.05 significance. And then we're gonna go through a conclusion. I've ordered my aims a little differently than I have in my dissertation, and there's a reason for that. So I'm going to go through aim 1, then 3, then 2. Aim 1 and 3 are the ones where I use the data from the healthcare system. And then aim 2 is the qualitative study, and it just flows better if we do aim 1 and aim 3 first and then aim 2. I do want to note that our this whole dissertation is framed within Anderson's behavioral model of health. And Anderson's behavioral model of health is designed to look at the factors that affect whether or not patients use care within a healthcare system. And they have 3 different groupings of factors: predisposing, enabling, and need factors. With aim 1, what we're able to look at is the factors that are in the healthcare system that are in the electronic data warehouse. So the electronic data warehouse is a place where patients' data is stored within the University of Utah system from clinical care, and it's accessible for research. So with aim 1, we're able to look at predisposing factors: obesity, aim 1 and aim 3, obesity, sex, age, race, see how they influence whether or not a patient uses physical therapy. Predisposing factors are the factors that drive whether or not a patient is probably going to need care or not. Enabling factors, which we're also able to look at, are a patient's ability, what increase a patient's ability to use care. So we're able to look at the costs, particularly what type of health plan. So we don't look at actual costs within what a patient is using, but we're able to look at if a patient's using commercial insurance versus Medicare, Medicaid, et cetera. We were able to look at the distance to the clinic. So I have to thank Mike Newman and the data science team for this. So we were able to geocode based on distance. And then we were also able to look at the diagnosis codes that patients had within the need category. So need factors are the ones that drive whether or not a patient is going to actually want to get care. Particularly like if you're for example, if a patient has a lot of symptoms, they're more likely to end up getting care than if they have a little bit of symptoms. So with a patient with shoulder pain, if they have a lot of symptoms, they'll go and get care, but if they have minimal symptoms, they're probably going to wait it out a little bit. What's unique with our projects is we were able to follow up AIM1 and 3's data, which uses that electronic data warehouse data, the retrospective data, and do a qualitative study and explore beyond what we can look at just by pulling data from a health system. So we were able to look at the social influences within the predisposing category, things that like friends and family might say to a patient that influence them, other cost factors, including co-pays, how familiar a patient is with the health system, once again, distance to the clinic, and then also, how much symptoms patients have, the provider's qualifications, what they think a provider, is one provider better than another? We were able to get patients' perspectives on that. And then also recommendations from past providers. So what I mean by recommendations is what other providers have told people when they've seen them. All right, I'm going to start with AIM1, which is the study that we did looking at patients after they get a referral, do they end up going to physical therapy or not? The purpose here was to look at the rate that patients use physical therapy after referral for a variety of different musculoskeletal diagnoses, expanding upon Ann's article and the 2019 pelvic floor article, while comparing the groups to see if there's any differences between those who use and those who do not use physical therapy after referral. So like I said, this study uses patient data from the University of Utah's electronic data warehouse. We included non-Medicare using adults, non-typical Medicare using adults with a new musculoskeletal diagnosis from a medical care provider. So what I mean by medical care providers, anyone who works in an ambulatory clinic might see someone with a musculoskeletal condition, could be physicians, nurse practitioners, PAs, apologize if I'm missing anyone, physician's assistants, and might give that person a referral to physical therapy. This was between October 1st, 2015 and September 30th, 2018. What I mean by a new musculoskeletal diagnosis is they had to have a brand new problem and they were coming in for a new problem. We screened for that by looking in the past to see if they did have any diagnoses. So if a patient had a back pain diagnosis and they came in and had another back pain diagnosis, they were screened and kept out. So they had to have a new diagnosis. All exclusion criteria was meant to basically take out patients who probably aren't going to benefit from physical therapy, including trauma, cancer, patients, outpatient physical therapy particularly. So if a patient was non-ambulatory, maybe wheelchair bound, we did actually take them out because they're probably going to need maybe more skilled care, and our focus is outpatient physical therapy. We did also screen for musculoskeletal diagnoses that we thought were most appropriate to see a physical therapist based on our clinical expertise. Users had to access physical therapy within 30 days of having that first visit with a medical care provider, which I'll refer to as an index visit occasionally. The reason we did that is we felt like it was enough time for a patient to have be able to get into the clinic and still have that visit related to that index visit. We included covariates, which are basically patient characteristics or characteristics of the system that we were able to access with the electronic data warehouse, including the geocoding of distance. So just a little bit more explanation about that. So we based it on a patient's zip code to the closest physical therapy clinic. And once again, Mike Newman was super helpful with that. It was his coding that allowed us to be able to pull that data from the electronic data warehouse. Our statistical analyses were focused on describing the two groups, the users and the non-users. We also ran several regressions to be able to put those characteristics within a model and see which ones came out as most predictive of physical therapy use. So we ran a Poisson regression That's our main regression. The reason we do that is because it gives interpretable risk ratios as opposed to odds ratios. So risk ratios allow you to look at a different percent of whether or not it's going to increase a patient's risk or ability to use physical therapy. A logistic regression we used to run a prediction model to take, hey, is our model going to be able to predict whether or not a patient's going to use physical therapy or not? Logistic regressions give you odds ratios, so they're not the results that I'm going to talk about, but I will talk about the results of the prediction model. Then we also ran several sensitivity analyses, including a time to physical therapy and the time to diagnosis. All right, so within that time frame, total patients that we pooled initially with an appropriate musculoskeletal diagnosis was just over 90,000. We excluded just over 4,000 for trauma, cancer, the things that I had talked about earlier. So we ended up including just over 86,000 that had probably were going to be appropriate to, we would think, for physical therapy if the physician or medical provider decided so. A good chunk of them had no referral, and then our focus is the group within that black box, those who were referred. So what I did is I created a graphic to explain this just a little bit more. So if we look here at the top, this is the breakdown of all the patients within the healthcare system who had a musculoskeletal diagnosis during that time that we think would be appropriate. So 82% were not referred. Of those referred, of the total group, 14% didn't go. So this leaves this little sliver of patients who ended up using physical therapy. We break down this referred group a little bit and come down here. The patients who did not use, of those referred, so patient got a referral, didn't use within our healthcare system, 76% didn't use physical therapy, leaving 24% ended up using. And that's that breakdown of those referred. What did the total cohort look like? About mid-40s in age, mostly female, mostly non-Hispanic, using commercial insurance, and with no comorbidities. This is pretty representative of Salt Lake sample, but it might not be representative of samples outside of Salt Lake. Okay, so what are the differences between the groups that come out? And with all these charts, I have bar graphs that I think explain these better. So I will go a little bit quickly through these because I think the bar graphs are easier to understand. But we found differences between the groups in obesity, payer, referral department, and distance to the clinic. What does this look like in a graph? So between the two, you can see that non-physical therapy patients who are not using physical therapy were obese 35% of the time compared to obese 29% of the time. They lived at a closer distance 81% of the time. The non-PT patients, the non-users of physical therapy, where the distance, the users, they tended to live a little closer, 0 to 10 kilometers. So all my distances are in kilometers, so that's about 6.2 miles. The referral from orthopedics was different between the two groups, and then the commercial payer was different between the two groups. What does this look like when we put it into the regression? And we found several different interesting findings, but I want to emphasize obesity just to explain risk ratios a little bit. So here what this means is if a patient is obese compared to a patient who is non-obese, so this is the reference category. So each one of these variables has a reference category. So it's compared to that reference. So if a patient is obese, a risk ratio of 0.84 means they are 16% less likely to use physical therapy if they get that referral compared to a patient who is non-obese. We can see in ethnicity, Hispanic ethnicity reduced risk of a patient's ability to use physical therapy. Payer reduced compared to commercial, Medicare, Medicaid. So we did have Medicare in this cohort, but they were probably patients who, if you're on Medicare and you're younger than 65, you probably have some other issues going on. Self-pay workers' compensation increased it. Once again, I have a chart that makes this more understandable. Orthopedics, the patient was referred from orthopedics compared to primary care, urgent care, or other specialties. Orthopedics, they had greater risk because primary care, urgent care, and other specialties reduced risk. Greater distance, no shocker there, decreased the risk of using physical therapy. What I mean by risk is that a patient's going to end up using physical therapy. These are epidemiological models. built for whether or not a patient's going to get sick. So they're based on risk. And then diagnosis code, back pain compared to back pain, hip, knee, and ankle and thoracic diagnoses increased a patient's ability to use physical therapy, their risk of using physical therapy. So what's nice about these risk ratios is now I'm able to make bar charts to show visually what happens when a patient has these risk factors compared to those comparison groups. So for obesity, for distance, so a distance of 20 plus kilometers compared to 10 to 0 kilometers, that patient had lived that far away from their health system. They were 66% less likely to use physical therapy compared to a patient who was referred and lived greater than 10 kilometers or less than 10 kilometers, excuse me. Part of the issue here might be because we included patients only within our health system and didn't include patients who might have gone to like Intermountain or another physical therapy clinic. So that might be contributing to that. If you look at back pain compared to ankle, knee, hip, and thoracic pain up here on the right, you can see that all those diagnoses increased a patient's risk of using physical therapy. If we emphasize where they're referred from, so a lot of patients most of our patients are referred from orthopedics. And I forgot to also mention that we picked the reference categories either based on how often they happen. So if they're most often happen, they were a reference category. Or for diagnosis, we chose back pain because there's a lot of evidence to say, hey, patients probably should use physical therapy for back pain because they have good outcomes. But it wasn't the most common found. So that's how we ended up that reference category for those 4 up there. But if we look at the primary care referral and the ER and urgent care referral, those greatly reduced risk, 47%. So if you got a referral from a ER or urgent care, you were 47% less likely to use physical therapy compared to orthopedics. If we look at payers, reductions compared to commercial payers, and then also Hispanic ethnicity and obesity reduce risk of using physical therapy. What do we pull from this study? So we know, to me, it seems like patients are rarely referred to physical therapy and infrequently use physical therapy after referral. This emphasizes the fact that what I was talking about, we had the past researchers either focused on the physical therapist or the provider, other providers. Patient choice is and their ability to access care are important drivers of medical use within the healthcare system. We need to start to shift our focus towards patients. There are patient and system level factors that I just discussed that influence patient use of physical therapy, including distance, ethnicity, payers. I do want to note that our predictive model, so we use that logistic regression to take 75% of the sample and then test it on 25% of the sample, and that gave us a receiver operating characteristic of 0.63, which is a poor predictive ability. And this emphasizes, well, it's number one, not too surprising based on how different our patients were within our model. So outside of those first characteristics that I talked about, there's a lot of different diagnoses in our model and a lot of patients that reduces our ability to create a really strong predictive model. But we do need to start to work on probably, subgrouping patients to see, hey, can we increase the predictive ability of our model? And I'll talk about the limitations after AIM 3. So what we did in AIM 3 is then we took this same cohort and we wanted to know, does it really matter if a patient accesses physical therapy or not? Looking at some sort of outcome. And the outcome we used was downstream medical use because it was accessible within the healthcare system. And patient-reported outcomes are not collected consistently enough across all the clinics that we used. Once again, but what we're doing is we're comparing patients' use of surgeries, injections, MRIs, and non-MRI imaging from their first healthcare visit between patients who use and those who do not. We use the same cohort at AIM 1, but we added the medical use data, the surgeries, injections, MRIs, and we had a window for that. So we had them from 30 days from their index visit up to 90 days. Anything in there was included in our analyses. We thought so we did this window because 90 days might be too long from that index visit to say, hey, it's probably related to that same problem. And then 30 days was So if they had that index visit and used something from that visit, that was probably meant to be actually included into their care. Because we're trying to figure out if physical therapy is going to affect medical use. We use similar statistics as AIM-1, but now we put physical therapy as the primary predictor because our hypothesis is that physical therapy is going to change medical utilization for the better. So we're going to reduce medical utilization. We did descriptive statistics, Poisson regression again. We did a negative binomial regression, mostly for sensitivity analyses. What negative binomial regressions allow you to do is look at the difference between patients, for example, for surgeries. With a Poisson, a patient who gets 5 surgeries is the same as a patient who gets 1. With a negative binomial, they're different. And then we looked at the association of medical use with diagnosis modified by physical therapy, and I'll talk about the reason why we did that when it comes to it. So what are the differences between the users and the non-users? In general, there are differences between the two with each group of medical utilization. And you can see that it looks like the physical therapy users have more use of surgeries, MRIs, injections, and imaging. But what happens when we put this into a model and look at it to see what happens when all those characteristics are put in? So there's a lot here. I understand that, but I do want to emphasize which things came out, and then I'll show them in graphs. So physical therapy use was associated with greater surgery use, greater MRI use, greater injection use, and imaging use. But with injections and MRIs, those numbers are quite small, although they are significant. We have an overpowered cohort here, so we got a lot of significance that might not be what's called clinically significant. But with MRIs and surgeries, a patient who uses physical therapy is 11% more likely to have a surgery within that 30 to 90 day window. A patient who uses physical therapy is 24% more likely to have an MRI within that 30 to 90 day window compared to a non-user. Obesity came out within surgery, so patients with obesity, 15% more likely. I'll talk about the diagnosis of lower back pain compared to the other diagnoses. I put them in a graph, but what I did is I switched the analysis just a little bit to compare lower back pain compared to all of those within the graphs. We had some interesting findings. Distance was once again predictive in imaging, actually reduced risk. Race, predictive in a couple. Charleston Comorbidity Index and Referral Department on the ones that I want to emphasize here. So consistently, what the Charleston Comorbidity Index says is like basically how sick is a patient. It takes a whole bunch of different measures and it gives you a count. So if a patient has no comorbidities versus a patient who does have comorbidities, consistently, they had increased risk of medical utilization across the board. A referral from orthopedics compared to, well, referrals from primary care, urgent care, and specialty care reduced risk compared to orthopedics across the board for all medical utilization. So if I pull out each one and look at, hey, what are the predictors for surgery use? So physical therapy is going to be mostly in the middle here, but you can see that physical therapy causes an 11% increased use. If we compare back pain diagnoses compared to a grouping of all the other diagnoses, a back pain diagnosis causes 75% reduction in surgery use. And I think this is because of those clinical practice guidelines and research that has been pushing for non-operative treatment for back pain. Urgent care and primary care, a referral from either one of those reduced risk significantly. So reduced risk, by 61% and 31% compared to a referral from orthopedics. That might be because once a patient's in orthopedics, they might have more severe symptoms and already on that surgery route, where Charleston increased it by 29%. If we look at injection use, pretty similar, once again, for urgent care, back pain diagnoses, primary care, physical therapy, a little bit less. Not sure if that's clinically significant, but it is statistically significant. The Charleston increased risk, and then obesity actually increased risk of injections here. If we look at MRI use, physical therapy, once again, increased use, Charleston increased use. This is where the distance comes out, distance greater than 20 kilometers. decreased use compared to a distance of 10 kilometers or less by 14%. Back pain in primary care, once again, very similar. What's interesting here with imaging is that primary care actually switches, right? So if you have a referral from primary care, you're 34% less likely to have imaging use compared to a referral from an orthopedic. Back pain in urgent care, 26% compared to their reference groups. And then distance greater than 20 increase in Charleston, greater than 1 increase by 10%. Here, physical therapy actually reduced risk, but we don't know if that's clinically significant. And all this imaging, I did forget to mention, is all non-MRI imaging. And we control for all this medical utilization to be related to musculoskeletal pain based on what was in the electronic data warehouse. Okay, so what we did with these findings is we were quite surprised because physical therapy, we thought, was going to reduce medical utilization across the board. So with the guidance of some of my mentors, we decided to then take physical therapy, run these models, but take physical therapy either in the model or out of the model and see if it changed anything. Because we really thought physical therapy was going to make changes. And I have highlighted surgery just for one reason, because they're all pretty similar, but I want to emphasize, like, you can see the percent change in the predictor compared to different diagnosis groups. So if you look at just cervical and we put physical therapy in the model or take it out of the model, what's the difference between that risk ratio? It's only very, very small. So this shows that physical therapy really had minimal impact on medical utilization when we separated by diagnosis groups. We separated also by diagnosis groups because past research has shown, particularly in back and neck pain, that physical therapy is effective at reducing costs and helping patients return to full function. So this shows that physical therapy, orthopedic referral, and comorbidities were associated with increased medical service use across the board. Back pain was associated with reduced use, which is not too surprising based on past research. And that physical therapy didn't really influence medical use outcomes by diagnosis groups. Limitations of AIM-1 and AIM-3, these are retrospective observational designs. So we can't say that, for example, Hispanic ethnicity is definitely going to reduce your risk of using physical therapy, or that having a back pain diagnosis means you're definitely not going to have a surgery. It's just, there's a relationship there. There's some association. We can't say it causes A causes B. It is a large study, right? So that it is overpowered. So we have a lot of significant findings that might not have been clinically relevant. We had a limited prediction model, the ROC curve on AIM-1. And all this data is only from one health system, and we were not able to track patients outside of the health system, limiting how translatable this information is to other health systems. The final study that we did was a qualitative study looking at how patients choose care for physical therapy for back pain. And I'll talk about why we chose a back pain group. The purpose here was to look at the factors that influence patient choice and access to physical therapy and other treatments for back pain using qualitative semi-structured interviews. Study was done on adults. No one was over 99 that I could recruit, so it didn't matter that we limited it to 99. They had to be English speaking because I can't speak any other languages. They had to use commercial insurance because they were included in the Rapid Access Program. So we looked at the Rapid Access Program, which is a program where we did that specifically because, number one, we used this partially as a quality improvement. We're able to get a little bit of funding because of that. And these patients were recruitable. The Rapid Access Program is created by Jake and colleagues, including Julie and Ann, where patients call the physiatry office, which is a sports non-op, sports med, for back pain. They often see that physiatrist in a week, couple weeks. But what this program was built to do is to get those patients into physical therapy early. So the call center picks up the call, talks to the patient, offers them a physical therapy visit within 72 hours. Because physical therapy is shown to be beneficial for back pain. And a lot of these patients ended up, if they see a physiatrist, they usually end up seeing physical therapy anyway. So let's get them in earlier. The rate that patients say no to this is around 70%, 69%. And what we did is we recruited 20 patients who accepted rapid access and 20 patients who did not, to look at the differences and look at what patients say and try to explore that choice. The interview was developed to basically try to reduce my bias. I'm a physical therapist. I think physical therapy is good as much as possible. It's semi-structured scripted, so patients have some flexibility in what they want to say. We use both question-based and global-based codes. The question-based codes are the ones that ask specific questions to the patients about. And then the global codes are more like things that we had hypotheses were probably going to be factors that influence a patient's choice within the healthcare system, including costs, what they think about other providers, et cetera. Question-based codes, there's 4 main ones. So by the end of the interview, I asked patients, hey, of everything we talked about, rank the most important factors that influence your decision. I also asked them which provider they saw first, the provider they believed was best to diagnose their back pain, and what they think is the best treatment for their back pain. These were coded only one time, where the global codes were counted. We did this until we basically heard the same thing over and over again, which is thematic saturation. And then the coding was done between me and Anne with guidance with Megan to reduce my bias as much as possible and make sure Anne and I agreed once again to reduce bias. What came out when I asked patients, hey, what is most important to you when you make choices within a healthcare system? So the bigger bubbles means it happened more often. The smaller bubbles means it happened less often. So provider training was first, costs, referrals and recommendations, symptoms, time, diagnosis, trust in their system, past experiences, reputation, and social. So I'm going to pull these out a little bit and we'll talk about the big ones. Of these most important factors that influence patients' choice, provider training came out the most, particularly with the non-rapid access patients. One patient in particular had tried physical therapy and primary care and felt that they quote unquote been exposed to like a shotgun method too many times, which caused them to quote unquote start to question credentials. So I'm starting up here and I'll go this way and then down. Another patient chose sports medicine because they thought of the sports medicine nature of the work and that they were more qualified to diagnose, compare and treat back pain than other providers. Several patients mentioned that costs were a driver within the healthcare system for them. I think one patient exemplified this particularly. They said, yeah, I think physical therapy is expensive. That's probably one of the biggest factors that they avoided physical therapy. And they mentioned that their co-pays are somewhere between $30 to $35. And if they have 8 visits, that ends up being a couple $100 and they weren't able to pay for that. Time and recommendations came out third most often. Those are 2 time, third, and recommendations fourth. So often recommendations were mentioned as a global code, but it was more of like, hey, my provider referred me, so I just went. So I didn't pull out any quotations for that. But patients mentioned time, particularly if they were in a lot of symptoms. One patient mentioned that the most important factor by far for them was the urgency, and they were able to get into physiatry very quickly, so they ended up choosing that. Another patient mentioned that they definitely would have taken the rapid access physical therapy appointment if they weren't. So that patient in particular got into physiatry within 24 hours of their call. But if they said, if their physiatry appointment was like the typical couple weeks out, they would have used the physical therapy. Symptoms and diagnosis were also important to patients. Symptoms in particular drove patients to just get care wherever they could on top of urgency. So a lot of patients had mentioned that I just went to whatever provider was open and was able to get me in within that day. With regards to diagnosis, a lot of patients would say things with regards to physical therapy and diagnosis and physiatry with diagnosis, and emphasize like, hey, I think the physician or other providers are better to diagnose. And these 2 quotes exemplify that. So one patient said, I really wanted someone to take a look at my back and determine there's something going on more than therapy can do. Another patient mentioned that the therapy folks, they're just not seeing the underlying processes that either cause injury or disease, and that physical therapy is needed once a diagnosis has been made by someone of merit, and they were referencing a physician. if we look at the question-based codes and the factors that influence choice and thoughts about care, what kind of comes out? So we've been going over the most important question. So what was most important factor influencing your choice? The rapid access group, they were pretty variable. They were kind of across the board, would say one thing or another. But the non-rapid access group would say 29% of the time they said provider training was important. 24% of the time they said costs were important to them. If we look at the choice first, who they ended up seeing first within the healthcare system, rapid access was 29% of the time they said primary, 12% of the time they said physical therapy. Non-rapid access tended to follow a more typical pattern within the healthcare system. What I mean by that is they would see primary first and then go to specialty from there. So 36% of the time they saw primary first. Between who you think the best provider is to diagnose your back pain, what was interesting here is both of them pretty frequently said the sports and back pain specialist, referring to either a surgeon or physiatry. Rapid access said it 78% of the time, the patients who said yes to rapid access. And then the non-rapid access said it 87% of the time. What was interesting now, so when I asked them, hey, what do you think is the best treatment for your back pain? 70% across the groups said exercise was the best treatment for them. And I'm going to talk about what I think that means in a little bit. So conclusions from the qualitative study is that patients are not avoiding physical therapy. I think contrary to what I had thought before, but I think what they're doing is they're trying to seek the best care they can receive from the highest quality providers, while also considering the health system's reputation. There is a clear disconnect between patients' ideas about who's going to diagnose their back pain, what diagnosis they need, and their belief of what treatment is best for their back pain. Physical therapists are the ones who provide exercise-based treatment. We are the exercise professionals, but patients don't think we can diagnose and don't see us as the first provider. They tend to think of other providers in that role as opposed to us, which I think is very interesting. Limitations. So we originally developed this thinking we were going to just look at the rapid access choice. That was very difficult. Patients' choices are made over time. Patients do a whole bunch of different things. There's a whole bunch of different factors, making it very difficult to look at that one choice at a specific period of time. So we ended up looking at their choices throughout time and also looking at different types of providers and treatments. What this information is going to allow us to do is hopefully we can address patients' perceptions and knowledge about physical therapy and then help address these barriers to increase appropriate access to physical therapy. So wrapping up all three studies, patient choice and access, based on all three of my aims, we've shown that patient choice and access are important drivers of healthcare use, and we really need to shift our focus, at least some of our focus, from the providers to the patients. We weren't able to adequately look at patient choice at the point where we're at now. I think more work is necessary, but multiple methods were absolutely needed. Obvious limitations that we've already talked about. The prediction model is limited, but I hope that with future directions, I'll be able to look at subgrouping maybe older patients or patients with mobility problems, and maybe they need the prediction model would be strengthened in them, and hopefully develop a patient-centric tool that directs the right patient at the right time towards physical therapy, because there's probably a decent amount of patients that get referred and don't need physical therapy and will do fine. We do have a limited external validity. We can't take these results and apply them to other systems because they're not comparable based on what the patient populations are. And then we need to do qualitative work in patients in more real world settings, right? So the rapid access program doesn't exist everywhere in healthcare systems. It only exists here. We need to look at actual patients after they're referred and do some qualitative work on them. There are my references. And I want to thank, once again, my committee, the university department, and the college. This wouldn't have been possible without help from all of them. The coding help I had from the department and a PT student, Chloe Rector, she was super helpful. It's not exciting to code, not code. She helped with the translation, which is not an exciting thing to do. The data science team, including Mike Newman. I wanted to thank the PhD students and other research collaborators, everyone who let me ramble on about this stuff and bounce ideas off them. The Rapid Access group is very helpful. They allow me to actually look at their patients. Friends and family, can never do it without them. And then also the funding that I had. So I had a small grant from the internal grant, the Imagine Perfect Care, and then the Foundation for Physical Therapy. All right, so I want to open it up for questions unless Anne wants to say anything before we start.
Great job, Jason. Thanks thanks for that. And you've obviously spent some time thinking about your graphics. Those are appreciated. So I will open it up for questions. And one thing you may want to do is put a question in the chat, and I'll kind of filter through those as well. But feel free to ask Jason in person.
Chris will also filter through them.
Oh, okay, thanks.
Hi, Jason. It's Jake. It was great to see a summary of your work there, and congratulations on coming to the conclusion of a lot of hard work. I was curious about your thoughts. You didn't really mention why you thought that the patients who went to PT actually had increased healthcare utilization for some of those high-cost procedures like surgery. And so I'm wondering if you can just expand on that.
Yeah, so I'm going to go back. While I'm going back, the main reason I think that occurred is, so I always look at surgery when I look at these because there are 4 different ones, but I think what's going on is because of where they're referred from. I think these patients are already on a path once they're referred from orthopedics or urgent care or primary care, that physical therapy might not change that as much. And so I think once they see that provider, they get on a certain path towards certain types of care, where physical therapy isn't making as much of a difference there. And there's kind of a washout because we are using so many different diagnoses. I honestly don't know. I can only hypothesize, but that's the biggest thing that I think is going on. Is like they get that referral for orthopedics, for example, and they're already on a path towards surgery or imaging already. And physical therapy is not going to change that very much.
Yeah, or maybe there's other things just generally about patients that attend physical therapy versus those that don't. Like, you really don't know much about the severity of their condition, right?
Not in this cohort, no.
I know, and so maybe it's not that they're on their path necessarily, but that it continues to develop into a worse condition, and just those people that those people that don't go aren't as bad. They don't need it.
Yeah. I mean, the people who use healthcare are probably going to use healthcare, right? So if they're using physical therapy, they might be also using other things at the same time.
Does this change your thought process related to AIM-1 with respect to we need to increase the? I sort of got a sense that we need to increase the number of patients that go to physical therapy. When they're referred, more people ought to go.
So I do not. It modifies it, I should say. So I think we need to really start to figure out, and by subgrouping, which patients are most likely to have a poor outcome and direct those patients, not all patients, to physical therapy, just which patients are going to have the worst outcomes.
Okay.
Okay, so we've got a couple of questions on the chat. From Caitlin, she asks, for AIM-2, did you control for patients who attended PT for pre-operative care? I guess I'm sort of surprised at the higher number of surgeries seen after PT.
I did not. So, and I'm not familiar if I was able to, so I didn't look at like the PT diagnoses. I only looked at diagnosis after that referral. So I feel like, yeah, sorry. I'm like answering Chris because he's the one reading the questions. So In my personal clinical experience, I don't think a lot of patients end up having preoperative care. I don't know what those numbers actually look like, and we didn't really we didn't control for that as much. We weren't able to control for that in this system, so that is a consideration. But you know, physical therapy was predictive of both MRI and injection use too. So you know, I'm not sure if that also supports that it's increasing surgery use, but I'm not, you know, food for thought.
Jason, this is Brooke. I actually posted this to the chat, but because you just mentioned it, I wonder if you could quickly go to your table of the effects of PT on downstream utilization. I think there's a typo or a misunderstanding or a misinterpretation on injections. So I think the slide before this, there you go. So you have injections have a association, PT has an association with injections. The confidence intervals here suggest that it's not significant, but you have a strong significance p-value. And this interpretation in your written dissertation, it at one time says that PT is a predictive of injections, and in another place it says it's not. So I think you have a bit of a confusion in the written stuff. You might want to go back and check that result.
Okay. I mean, looking at it now, it does cross zero. It does, the confidence interval does include zero. And
Crosses
it's
one.
probably, what was that?
Crosses one.
Crosses one. Yeah, thank you. You know, and it's probably significant because the numbers are so large. So I would agree, it's probably not clinically significant, although statistically the p-value is significant.
I think it should not be statistically significant because it crosses one.
Okay.
So, yeah.
Right.
I can double check that.
And you'll want to check that in the written document too, because it does, your chapter interprets that both as a not significant and a significant association in various places.
Jason, just quick, this is Jesse, just had a quick question, maybe clarification on my front, but it seemed like your surveys were related to patients that were referred to PT. But if I'm understanding the AIM 1 and some of the data you showed, it appeared that 80% of MSK patients were not referred to PT. And if that's the case, I was wondering if this has been done or if you have any future interest in actually looking at the provider and what their thoughts are of why they're not referring MSK patients to PT, and if that would be in line with training cost and you know, surgery or symptoms and diagnosis that you found on the patient's perspective. And just wanted to kind of get your thoughts on maybe just the provider that's looking to refer these patients to us, in general thoughts there. And if I missed that, just a clarification.
I had someone come in the room in the middle of that, so I apologize. It was a long question, but do you mind restating?
Yeah, basically just the surveys or the interviews that you conducted were on the patients that were referred to PT, is my understanding. But initially it looked like, and maybe this is what I missed, but it looked like 80% of MSK patients were not referred to PT by the provider. I was curious if there's anything, what is out there, or what your thoughts are on interviewing the providers of why those patients aren't referred, and if those are potentially in line with the patient's perspective of issues with training, cost, and symptoms diagnosis, the things that you found in your interviewing of the patients.
Yeah, there's a lot there. I'm going to try to answer as much as I can. So the interviews were just of patients of the rapid access program. So those patients might not have actually been referred. So we were looking at, you know, their choices within the healthcare system, but also with regards to whether or not they said yes or no to that rapid access program. It was about 80% were not referred. I think there's value in interviewing the providers, but based on past research, it does seem like referral rates are increasing, but use rates aren't increasing. So, the reason I focus more on the patients is because I think that was the better way to go. But I don't think that there's not value there, because there's probably patients within that 80% that aren't getting referred and probably do poorly. And we don't know really what's going on in the provider's office at all. So I think it's definitely valuable. Does that answer? I think there was like four
that's
questions.
great. And maybe just a clarification. So that initial data you showed in AIM-1, I think it was something like 82% of patients. Were those MSK patients that were not referred, or was that just patients in general?
All patients with MSK diagnosis, that's probably appropriate to go to physical therapy, controlled for by us. So it's based on our criteria.
Right. Yeah. To me, that's really interesting data right there. I mean, the focus on the 14% of patients that were referred is obviously very relevant, but I mean, it seems like the big issue here is the provider. 82% of those that likely should be patients we potentially should be seeing. Why is that? Are they small, simple things that really don't need a skilled provider or professional to see? Or is there something about providers that they maybe don't understand that we do? I think that could be really interesting future work with kind of expanding on your dissertation.
Yeah, I agree. I mean, we're missing all 82% there, and then also 76% there. So it's a large chunk of patients.
Right.
We've got some questions that people have asked on the chat. So the next one is from Dr. Fritz. She asks, for AIM-1, what factors do you hypothesize are missing from your prediction models that could improve the explained variance?
Yeah, that's a good question. And I think without saying like most of those are probably within the qualitative analysis. If we could understand more about what are like barriers to a patient accessing physical therapy, including like the copay costs, I think that might help improve the prediction model. I think if we start a subgroup, that will help it too. And then also maybe pain, Jake kind of mentioned this too, pain and symptom levels. If we could include those, and maybe functional level with a patient-reported outcome, like if they had a promise beforehand, we could see like, hey, if maybe a patient has a lower promise, we were able to put that in the model, like low, high, or categorize, we might be able to see a difference there. So including those three.
Jason, this is Brooke. Regarding AIM-1, number 1, you framed a lot of your dissertation in the context of Anderson's model, which includes predisposing, enabling, and need factors. From your model, as I read your model, you are mostly showing larger effects for the factors in the model that relate to enabling or access to care. And so my question is, and I think even though you're sort of limited on the amount of need variables, it's kind of moot, because given a referral, all these patients, we can safely assume that all these patients had a need for PT, trusting that the referral was appropriate. So just between sort of the predisposing and enabling, it seems largely driven by enabling factors. And so I'm wondering what recommendations you would have to a health system or a community that would help alleviate some of the barriers to care.
So I think this is a very timely question, especially with COVID and the pandemic. I think, and I also work in telehealth, so I think telehealth is a great option to really reduce those and improve patients' enabling ability to access care. There is limitations there, internet limitations, while also, there's a whole bunch of different factors that can limit a patient's ability to access telehealth. But, also shifting and making it so patients are able to access care, maybe with transportation problems, more clinics, maybe, home care beyond just like the typical patient who has home care, which is mobility deficits, like allowing therapists to go to the home of a patient maybe who has more barriers to accessing, like financial barriers or et cetera. I think, expanding home care maybe, and then I think definitely telehealth would probably be the best way to address some of those enabling problems.
So Jason, I'm going to jump in here because I think this brings up a really interesting point. So the first thing I would suggest is your interviews suggest to me that I wouldn't dismiss the idea that everybody needs physical therapy because the physician said they did. Because I think the other piece here that's you're unable to gather from administrative data is, does the patient think there's value in physical therapy that's going to help them achieve their goals? And I think that would fit into that need idea. And it sounds like to me from your qualitative work, which really comports well with what's in the literature about what patients, some of the barriers that patients have about what they're seeking when they go into care, that this idea that they want somebody to reassure them that nothing is really seriously wrong and they don't perceive a physical therapist can do that. That comes out again, and that's their need. And once that need is met, presumably by the physician, they perhaps don't perceive that there's a need or a benefit to them or value in physical therapy. And there's no way to get that from EHR data. But I was also thinking, as you brought it up in the talk, kind of the opposite in thinking about the circumstances we find ourselves in now and remote visits. And some of this is my experience with some clinical research that's going on and talking to patients who were in the middle of physical therapy when everything changed, or we were trying to schedule in physical therapy, and they're really not that keen on remote physical therapy visits. And again, if what patients are looking for is a lot of reassurance and connection to that provider, I'm not sure your data suggests that telehealth is an answer. I think it might suggest it is going to be an additional challenge. So I'd like maybe to hear you comment a little bit more on maybe what that qualitative piece would suggest in terms of the potential role of remote visits.
Yeah. What I foresee moving forward, and maybe this helps, partially answers your question, Julie, and Brooke's question, is some sort of shared decision-making or patient-centric tool that gives patients that reassurance and says, hey, you're probably okay, you need to move, and increases their access to that. But to do that in a cost-effective manner that's not either phone calls or telehealth is I think, very challenging. You can integrate within a clinic, but I foresee it more as a phone call of those patients who are most likely to have a poor outcome and not use physical therapy, but need to actually end up going to physical therapy. So, I think once patients maybe become more, in my experience with telehealth, patients love it, but they also weren't the patients like you're talking about, Julie, that were in the clinic and now they're out of the clinic. So I think it's maybe a little bit of like a cultural change of healthcare, but while also figuring out which patients really need that in-person visit and then modeling both, modeling intervention based on what a patient wants and needs. Yeah.
Was that the downstream health utilization question?
No, I don't think so.
Okay. So next question from the chat is from Josh Johnson. He says, so in hindsight, how do you feel about using downstream healthcare utilization as your primary outcome for AIM-3?
Yeah, not thrilled. I think it could be an outcome that I continue to look at, but if I could collect patient-reported outcomes, if we had promise enough within the healthcare system, the problem was we just didn't have it frequently it wasn't collected enough within like primary care and urgent care, et cetera. Or there's a lot of patients who go to urgent care and don't come back. And then also if we could start to collect some cost data to really make that a little bit more robust. So I think it's useful. I think on top of just using medical utilization, if we could collect costs and then also some sort of functional outcome, those would be useful, but they probably would have to be smaller cohorts to make sure we got every patient, maybe a survey study.
Just a follow-up to that, Jason. So how do you think these results would be different if we had patient-reported outcomes?
Well, I thought the results were going to show reduced utilization. So I really don't know. So I'm kind of, my hypotheses were that like therapy was good, right? And it was probably going to reduce utilization. And now knowing what I've shown today, I almost can't answer that question because I'm just I'm not sure what would come out. You know, maybe the patients like Jake had mentioned, like, you know, these people who use physical therapy might be already high utilizers of healthcare, but those people who use physical therapy might be more likely to exercise and already have good outcomes. So it might not show any difference there either. But until we expand and look at that, we're not going to know. It's really hard to come up with a hypothesis now because, like, you know, my brain's kind of spinning after doing this because I really thought therapy was going to improve outcomes, at least the ones we had.
I don't think you can fairly equate downstream utilization with improved outcomes necessarily, though. So I think you need to be careful on the language there.
Okay. Yeah. I mean, it's a proxy, and yeah, especially functional outcomes. I mean, downstream utilization doesn't mean that a patient's going to improve their PROMIS score or not, either way.
And that downstream utilization could be a good thing if you don't know if it's tied to an outcome.
Yeah.
Right.
Right.
Yeah, and you could end up, just to add to that, you know, if you did this comparison with patient-reported outcomes, you could find that their PROs are worse for those using PT because it's a sicker, you know, group of patients, higher utilizers, et cetera. And it's not really a fair comparison. Just because they're using it doesn't mean that PT isn't effective, because it could just be the patient population that's causing, you know, lower PROs than patients who are not using PT.
All right. Last question from the chat so far was from Danica, and she asks, or she says, as you stated, the majority of patients thought that exercise was the best treatment. Was it your impression that they knew PT could offer them individualized exercise treatment plans, or are there things we need to do as PTs to market ourselves differently?
Oh, it's definitely a marketing problem. And that's a great question, Danica, because patients from the qualitative studies, like I said, they don't think PTs can diagnose, and we can definitely diagnose back pain. And they generally don't know what we do as physical therapists. So all the PTs on this might smile about this, but like pretty consistently or anecdotally during the qualitative interviews, patients were like, oh, PTs massage, they do ultrasound. And that was like the two big things that people said. You know, they don't really understand what therapists do. And I think, as you know, without going too far into advocacy, we could definitely the profession might be able to do a better job of saying, hey, this is what we do, because patients don't understand that. That doesn't mean they don't understand other aspects of the health system too, though. But they definitely don't understand physical therapy, from what I understand during the qualitative studies.
Jason, a general question. You mentioned that you would send the paper, essentially the qualitative findings, out to the participants. When you did that, what kind of response did you get from that?
I got one that mentioned I had a typo, two that said no problems, and then no responses beyond that.
So no one changed their answer or corrected anything? That's interesting.
No, and I purposely, when I sent it, for each patient that I quoted, I was like, hey, I highlighted your quotes. Take a look and let me know if you don't agree or anything. And I haven't sent reminder emails, but I did send at least one email to them, and I haven't heard anything, which I'm not too surprised about, but.
Great.
Jason, I just have one more question if we have time.
Yep.
It seems like a major theme of your qualitative work was, or that emerged, was that patients don't know what PTs really do.
Yeah.
I'd say that extends well beyond patients and also goes to providers too, in many cases. And it's the age old problem with physical therapy, is that we're viewed in some cases kind of like a black box, and people don't know what happens. And so you mentioned something about advocacy. And so this is just a big, broad picture question. That seems like that would be something that you would really emphasize in your, those findings would be something you'd emphasize in a manuscript. What would you then recommend, to improve the exposure of what physical therapists do to the public that hasn't already been done?
Oh man, that's a good question. I've been thinking mostly on like a patient to provider scale, where the provider would provide that the PT would provide that education to the patient, maybe in a phone level, but it's got to be some sort of on a large scale marketing, hopefully publishing of these results, and then. I think that would be something that would be better left in the hands of like the APTA than me, because I've spent 4 years doing this research degree, so I don't really know, marketing wise, what would be good for getting that out besides, number one, implementing this within a system, decreasing that lag time from like research being published to being put into practice, and beyond that, and the market, I'm not sure on the marketing level, but that would be an APTA, I think, expertise. I would leave it up to them, probably.
Okay. Probably wasn't a very fair question. Thanks for that.
All right, so I think from this point we will move. Jason, you should check the chat. You're getting a lot of congratulations, but we're going to move ourselves, or Chris will move the committee and Jason into our own breakout room. But if you'd like,
and just for just real sorry to interject here, just for all the PTs on the call, I think you all have a lot of merit. Despite your qualitative interviews.
Thanks, Brooke.
Doggone it, people like me.
Megan, Jake, Julie, Ann.
We're going into the breakout room. If you guys want to stay on the call, when we kick Jason out, you'll get a chance to chat with him.
We might, hopefully the breakout works, but there's always potential to.
Oops. And you, Jake, Julie, and Megan.
And Brooke.
All right, I got it. I'm on it. Got to delete. Sorry, everybody. Or I could just. Oh my God. Everybody's leaving. I could just probably leave you here.
We're figuring it out.
No, I accidentally left.
You left?
No, I left a time lag, a 60-second time lag when you close a breakout room. And I set it up wrong, so I have to close it and open it again.
So we gotta wait 60 seconds.
Wait a minute. And believe me, when you wait a minute for something.
That minute can wait, seem like forever.
All right.
Was that your research? Was that?
Hello?
And Brooke. Jake. So you and Brooke, Jake, and Julie.
And wait, say it again.
You and Brooke, Julie, Megan,
Yes, I think so.
and Jake.
Yes,
All right.
I should have given you a list.
It's all good.
This part probably would have been smoother in person.
Super smooth. I think that's all that's left here is the committee. So the only person who needs to leave is me. Bye, everybody.
Thanks,
No.
Chris.
Mike is, Robin's still here.
Okay, well then never mind. I will.
We're still working on it. Oh, wait. Is Brooke gone?
No, Brooke's here.
I'm
Uh,
here. It shifted me to a breakout session and then it canceled itself and came back to the main room.
Yeah.
Yep, that's me.
We could just boot Paul and Robin.
Boom.
Yeah.
You're all in there.
Or
Do
do we
you-
have to join it?
You're all
I have
in.
I have another request to join. Should I join?
Yes.
Yes.
This is the correct.
Okay,
Okay, I'm joining too.
I think it worked.